Hello, this is Emergency Care and Transportation of the Sick and Injured, Chapter 17, Neurologic Emergencies. Upon completion of this chapter and the related coursework, you will understand the significance and characteristics of the following: anatomy and physiology of the nervous system, common disease processes including strokes, seizures, headaches, and altered mental status, assessment and basic care management involving patients with neurologic emergencies, including performing tests for speech, facial movement, and arm movement, and assistance of the ALS provider in managing these neurologic emergencies. Stroke is the fifth leading cause of death and the leading cause of adult disability in the United States, according to the American Stroke Association. It is common in geriatric patients. Contributing factors for stroke include family history and race. African Americans, Hispanics, and Asians have a much higher risk of stroke. Treatments are available for stroke. Many hospitals are certified stroke centers, and rapid transport is absolutely vital. Seizures and altered mental status may also occur when there is a disorder in the brain. Seizures may occur as a result of a recent or prior head injury, a brain tumor, a metabolic problem, fever, a genetic disposition. Altered mental status is a common presentation in patients with a wide variety of medical problems. Some possible causes include intoxication, head injury, hypoxia, stroke, and metabolic disturbances, and treatment varies widely. Let's talk about the anatomy and physiology involved. The brain is the body's computer. It controls breathing, speech, and all other body functions. There are three major parts to the brain: the brainstem, cerebellum, and cerebrum. The cerebrum is the largest part of the brain. The figure on this slide illustrates the three major parts of the brain that I just mentioned: the cerebrum, the cerebellum, and the brainstem. The brainstem controls the most basic functions: breathing, blood pressure, swallowing, and pupil constriction, etc. The cerebellum controls muscle and body coordination, such as walking, writing, picking up a coin, playing the piano. The cerebrum, located above the cerebellum, is divided into right and left hemispheres. Each hemisphere controls activities on the opposite side of the body. The front of the cerebrum controls emotion and thought. The middle part controls sensation and movement. The back part is sight. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum. Messages sent to and from the brain travel through nerves. There are 12 cranial nerves that run directly from the brain to different parts of the head. 4 of them are the eyes, ears, nose, and face, the nerves that control the eyes, ears, nose, and face. The rest of the nerves, those are 8 of the cranial nerves, other than the eyes, ear, nose, and face, join in the spinal cord and exit the brain through a large opening in the base of the skull called the magna foramen, or the foramen magnum. Either way is correct. At each vertebra in the neck and back, 2 nerves branch out. These are called spinal nerves. They send signals to and from the body. The figure on this slide illustrates the intersection of the skull and spinal cord. The spinal cord exits the skull at the foramen magnum, and 2 nerves branch out of the spinal cord at each vertebra in the neck and back. Now let's discuss pathophysiology. Many different disorders may cause brain dysfunction and may affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is most sensitive to changes in oxygen, glucose, and temperature levels. A significant change in any one of these levels will result in a neurologic change. As a general rule, if a problem is caused primarily by disorders in the heart and lungs, the entire brain will be affected. If the primary problem is in the brain, only part of the brain is affected. Now let's discuss headaches. Headache is one of the most common complaints you will hear from your patient in terms of pain. Headache can be a symptom of another condition, or it can be a neurologic condition on its own. Only a small percentage of headaches are caused by a serious medical condition. Tension headaches, migraines, and sinus headaches are the most common types of headaches. The first type of headache we're going to discuss is tension headache. Tension headaches are caused by muscle contractions in the head and neck and are attributed to stress. The pain is usually described as squeezing, dull, or as an ache. They usually do not require serious medical attention. Migraine headaches are thought to be caused by changes in the blood vessel size in the base of the brain. Both adults and children can experience migraines. Women are 3 times likely to have headaches compared to men. The pain is usually described as pounding, throbbing, and pulsing. Migraines are often associated with nausea and vomiting and may be preceded by visual warning signs such as flashing lights or partial vision loss. Migraine headaches can last for several hours to several days. Sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities. Patients may also have cold-like signs and symptoms of nasal congestion, cough, and fever. Pre-hospital emergency care is not required for sinus headache. Serious conditions that include headache as a symptom are hemorrhagic stroke, which is bleeding in the brain tumor, and meningitis. You should be concerned if the patient complains of a sudden onset severe headache or a sudden onset headache that has associated symptoms. You should suspect a stroke in patients with a severe headache, seizures, and altered mental status. Signs of increased intracranial pressure, or ICP, include headache, vomiting, altered mental status, and seizures. Increasing ICP may be caused by a hemorrhagic stroke, tumor, or some recent head trauma. Your patient assessment should include asking the patient if he or she has experienced any recent head trauma. Consider not using lights and siren during transport. The lights, especially if they cycle at 3 cycles per second, for some reason that pattern seems to be the biggest trigger. But any type of flashing strobe, flashing lights, sirens can trigger a seizure. Now let's discuss stroke. A cerebrovascular accident, CVA, or more commonly referred to as stroke, is an interruption of blood flow to an area within the brain that results in the loss of brain function. Lacking oxygen, brain cells stop functioning and begin to die within minutes. Once brain cells die, there isn't much that can be done. Brain cells develop ischemia, which is the reduction in blood supply that eventually results in inadequate oxygen being supplied to the cells, causing those cells to stop functioning properly. It may take several hours or days for cell death to occur because there may be small trickles of blood keeping the ischemic cells alive. With prompt restoration of blood flow, the cells will not die and function can be preserved or restored. As for types of stroke, there are 2 main types of stroke: ischemic and hemorrhagic. An ischemic stroke occurs when blood flow through the cerebral arteries is blocked. In hemorrhagic stroke, a blood vessel ruptures and the accumulated blood causes increased pressure in the brain. Ischemic stroke is the more common type of stroke, and according to the American Stroke Association, accounts for more than 80% of strokes. This occurs when blood flow to a particular part of the brain is stopped by a blockage, such as a blood clot inside a blood vessel. This blockage can be due to thrombosis, where a clot forms at the site of the blockage, or due to an embolus, where the clot forms in a remote area and then travels to the site of blockage. In other words, you can get like a blood clot and it will travel through the circulatory system, but eventually it gets lodged in a small blood vessel, and most commonly the small blood vessels in the brain. And it gets into that small blood vessel, it's too large, and the result is blockage, and then oxygen deprivation to that area of the brain that particular blood vessel supplies oxygen to normally. Symptoms in ischemic stroke may range from nothing at all to complete paralysis. Atherosclerosis in the blood vessels is often the cause of ischemic stroke. Atherosclerosis is the disorder in which calcium and cholesterol build up, forming a plaque inside the walls of the blood vessels. This plaque may obstruct blood flow and interfere with the vessel's ability to dilate normally. Eventually, it causes complete occlusion of an artery. Even if the blockage in the carotid artery, for example, is not complete, smaller pieces of the clot may break off and embolize deep into the brain and become lodged in a smaller branch of blood vessel, blocking blood flow and thus oxygen supply. And that's what I was just talking about briefly at the end of the previous slide. Hemorrhagic stroke accounts for about 13% of strokes, according to the American Stroke Association. It results from bleeding inside the brain. Blood forms a clot which compresses brain tissue next to it, and this compression prevents oxygenated blood from getting into the area, and the brain cells begin to die. Cerebral hemorrhages are often fatal. People at high risk include those experiencing stress or exertion. People at highest risk are those who have had very high blood pressure or long-term elevated blood pressure that is not treated. Blood vessels in the brain become weak because of the pressure, and if a vessel ruptures, the bleeding in the brain will increase the pressure inside the cranium. Now let's discuss aneurysm. An aneurysm is a swelling or enlargement of the wall of an artery resulting from a defect or weakening of the arterial wall. A symptom of aneurysm may be the sudden onset of severe headache. When a hemorrhagic stroke occurs in an otherwise healthy young person, it is likely caused by a weakness in a blood vessel called a Barry aneurysm. Surgical repair may be possible if care is sought immediately. Now there is this particular type of assault on the brain, which is called transient ischemic attack, also known as a TIA. When blood flow to the brain is obstructed due to atherosclerosis or a small blood clot, the patient may exhibit signs of a stroke. When stroke-like symptoms go away on their own and in less than 24 hours, the event is called a transient ischemic attack. Some patients call these mini strokes. No actual death of tissue occurs with a TIA. Because symptoms of a TIA can last up to 24 hours, you may not be able to differentiate between a stroke and a TIA. And the truth is, you most likely will never be able to tell the difference on scene between a stroke and a TIA. Although most patients with TIAs do very well, every TIA is an emergency. It may be a warning sign that a more significant stroke may be imminent in the future. About 1/3 of patients who have TIA will experience a stroke soon after a TIA. There's another reason that you not only cannot differentiate in the field, but shouldn't take the time to try to differentiate. Because, as it states here, about 1/3 of patients who have a TIA will experience a full stroke soon after. All patients with a TIA should be evaluated by a physician. Now let's talk about signs and symptoms of stroke. General signs and symptoms include the following: facial drooping, sudden weakness or numbness in the face, arm, leg, or one side of the body, decreased or absent movement and sensation on one side of the body, lack of muscle coordination, ataxia, or loss of balance. The patient may also present with sudden vision loss in one eye or blurred and double vision, difficulty swallowing, decreased level of responsiveness, and speech disorders. Aphasia is difficulty expressing thoughts or inability to use the right words, which is expressive aphasia, or difficulty understanding spoken words, which is receptive aphasia. Slurred speech is called dysarthria, and that may be present. And they may also have sudden and severe headache, and general confusion and dizziness. Some additional things they might present with are weakness, combativeness, restlessness, tongue deviation, and they may lapse into full coma. Now let's discuss the left hemisphere of the brain. If a stroke occurs in the left hemisphere, it may cause aphasia. Aphasia is the inability to produce or understand speech, and speech problems can vary widely in these patients. Strokes that affect the left side of the brain can also cause paralysis to the right side of the body. With right hemisphere stroke, it can cause paralysis on the left side of the body. Now, usually with a right hemisphere stroke, patients will understand language and be able to speak, but their words may be slurred and hard to understand. Patients may also be oblivious to their problem, and this symptom is called neglect. Patients with a problem affecting the back part of the cerebrum may neglect certain parts of their vision. Neglect and lack of pain can cause many patients to delay seeking help. They don't really perceive that there's anything wrong. On the inside, as far as they're concerned, everything's functioning normally. But to others, they will present one or more of the symptoms that I mentioned. Bleeding in the brain can occur when the patient has very high blood pressure. It may be the cause of bleeding in the brain, or it may be caused by the bleeding itself as a compensatory response. A trend of increasing blood pressure is an important sign, as the body must increase the blood pressure to get blood to the brain's tissues. So the brain is telling the body to increase blood pressure to try to keep the blood coming, because of course it carries the oxygen it needs. Significant drops in blood pressure may occur as the patient's condition worsens. Monitoring the blood pressure for changes in these patients is extremely important. Conditions that may mimic stroke are hypoglycemia, where there's not enough blood glucose, post-ictal state, which is a period following a seizure that lasts between 5 and 30 minutes and is characterized by labored respirations and some degree of altered mental status. Subdural or epidural bleeding, which is a collection of blood near the skull that presses on the brain. that can also mimic stroke. The figure on this slide illustrates intracranial bleeding. Trauma to the head may result in intracranial bleeding, and then also you can have bleeding outside the dura and under the skull, which is called epidural bleeding. And bleeding beneath the dura but outside the brain is called subdural bleeding. And you can see these illustrated in these images on this slide. A seizure is a neurologic episode caused by a surge of electrical activity in the brain. It can take the form of a convulsion characterized by generalized uncoordinated muscle activity and or can be associated with a temporary alteration in consciousness. In the United States, it is estimated that 2 to 3 million people have epilepsy, which is a common cause of seizures. Seizures are classified into two basic groups, which are called generalized and partial or focal. The first one we're going to talk about is the generalized seizure. A generalized seizure is called a tonic-clonic seizure, and this type of seizure results from abnormal electrical discharges from large areas of the brain, usually involving both hemispheres. It's typically characterized by unconsciousness and a generalized severe twitching of all muscles that lasts several minutes or longer. In other cases, the seizure may simply be characterized by a brief lapse of consciousness in which the patient seems to stare and not respond to anyone. This type of seizure does not involve any changes in motor activity. It's called a petit mal or absence seizure. The most common way it is referred to is petit mal seizure. The other type of seizure that I mentioned at the beginning of this slide, where you have full body convulsions, are called grand mal seizure, because it's not only an electrical storm in the brain where everything kind of freezes up in the brain, it also produces twitching and sometimes very violent twitching through the muscle groups in the body. That's a grand mal seizure. Petit mal seizure is the electrical storm taking place only in the brain without uncoordinated muscle movement. Either way, it's a seizure. A partial or focal seizure, if you remember I mentioned this a couple of slides back, is the type of seizure that begins in one part of the brain and is classified as simple or complex. A simple partial seizure presents no change in the patient's level of consciousness. Patients may have numbness, weakness, dizziness, visual changes, or unusual smells and tastes. They may also have some twitching or a brief paralysis. With a complex partial seizure, the patient has an altered mental status and does not interact normally with his or her environment. This results from abnormal discharges from the temporal lobe of the brain. Other characteristics may be lip smacking, eye blinking, and isolated jerking. Patients may also experience unpleasant smells and visual hallucinations, exhibit uncontrollable fear, or perform repetitive physical behavior. Now let's discuss aura. Patients may experience an aura prior to a seizure. It can include visual changes such as flashing lights or blind spots in the field of vision, or hallucinations where they're seeing, hearing, or smelling things that are not actually present. People with a history of seizures recognize their auras and usually take steps to minimize injury, such as sitting or lying down. Auras do not occur prior to every seizure, and not all patients with a seizure disorder experience an aura. Now, generalized seizures are characterized by sudden loss of consciousness, followed by a chaotic muscle movement and tone, and apnea. During a generalized seizure, a patient may exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and then muscle relaxation, usually lasting 1 to 3 minutes. The patient exhibits tachycardia, hyperventilation, sweating, and intense salivation. Most seizures last 3 to 5 minutes. A postictal state of 5 to 30 minutes follows, in which the patient is unresponsive at first and then gradually begins to regain consciousness. In contrast, an absence, which is formerly called a petit mal seizure, may last for just seconds, after which the patient fully recovers with only a brief lapse in memory. So the absence seizure or petit mal seizure is the storm only in the brain versus the full generalized seizure, formerly called grand mal seizure, which a lot of people still use these terms. And the grand mal seizure is not just an electrical storm in the brain, but also produces muscle contractions throughout the entire body. Seizures lasting more than 5 minutes are likely to progress to a state known as status epilepticus. Seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. This slide shows causes of seizures. In some seizure disorders, such as epilepsy, these seizures are congenital. Others may be caused by high fever, structural problems in the brain, metabolic or chemical problems in the body, or may be idiopathic, where the cause cannot be determined. Epileptic seizures usually can be controlled with medications. Medications used most often to treat seizures include levetiracetam, which is Keppra, Ventolin, which is Dilantin, phenobarbital, carbamazepine, which is Tegretol, valproate, which is Depakote, topiramate, which is Topamax, and clonazepam, which is Klonopin. Seizures may also be caused by an abnormal area in the brain, like a structural cause, which is a benign or cancerous tumor, an infection, such as a brain abscess or meningitis, or scar tissue from some type of injury. Seizures from a metabolic cause can result from abnormal levels of certain blood chemicals, hypoglycemia, poisons, drug overdoses, sudden withdrawal from routine heavy alcohol or sedative drug use, prescribed medications, and then seizures can also result from sudden high fevers, particularly in children. These types of seizures from sudden high fevers are known as febrile seizures. Always transport a child who has had a febrile seizure for evaluation in a hospital. It is possible that a second seizure may occur. The importance of recognizing seizures can't be understated. You must recognize when a seizure is occurring and whether this episode differs from previous ones. A patient may turn cyanotic from a lack of oxygen in the blood. Seizures may prevent the patient from breathing normally. In a patient with diabetes, the blood glucose level may decrease. If your local protocol allows, closely monitor blood glucose levels after a patient with diabetes has had a seizure. You must look at other problems associated with the seizure. Patients who have fallen during a seizure may have a head injury. Patients having a generalized seizure may also have experienced incontinence. The postictal state is what we're going to discuss now. Once a seizure has stopped, the patient's muscles relax, becoming almost flaccid or floppy, and the breathing becomes labored, very fast and deep. This breathing pattern helps the body balance the acidity in the bloodstream. With normal circulation and liver function, the patient will begin to breathe more normally within minutes. In some situations, the post-ictal state may be characterized by hemiparesis, which is a weakness on one side of the body resembling a stroke. The post-ictal state is most commonly characterized by lethargy and confusion, and the patient may be combative. You must be prepared for these circumstances. If the patient's condition does not improve, you should consider other possible underlying conditions, such as hypoglycemia or infection. Syncope is fainting, and seizures are often mistaken for syncope or fainting. Fainting typically occurs when a patient is standing. Seizures may occur in any position. Fainting is not associated with the post-ictal state. Aside from stroke and seizures, the most common type of neurologic emergency that you will encounter is a patient with an altered mental status. The patient is not thinking clearly or is incapable of being aroused, woken up and brought around to responsiveness. In some cases, the patient will be unconscious. In others, the patient may be alert but very confused. Causes include hypoglycemia, hypoxemia, intoxication, delirium, drug overdose, unrecognized head injury, brain infection, body temperature abnormality, brain tumor, and an overdose and/or poisoning. Causes of altered mental status, when we're discussing those, let's talk first about hypoglycemia. Patients can have signs and symptoms that mimic stroke and seizure. In these cases, the patient may have hemiparesis, similar to what occurs as a result of a stroke. The principal difference is that a patient who has had a stroke may be alert and attempting to communicate normally, whereas a patient with hypoglycemia almost never is able to communicate normally and almost always has an altered or decreased level of consciousness. Patients with hypoglycemia commonly, but not always, take medications that lower the blood glucose level. These patients with hypoglycemia can also experience seizures. The mental status of a patient with hypoglycemia is not likely to improve even after several minutes. Consider hypoglycemia in a patient who has altered mental status after an injury such as a motor vehicle crash. Delirium is a symptom, not a disease. It's a temporary state that often has a physical or mental cause, and it presents as a new complaint rather than a long-standing alteration in behavior. And this temporary state that has a physical or mental cause can be caused by infection, changes in medication, hypoxia, and it may be reversed with proper treatment. Signs and symptoms include confusion and disorientation, disorganized thoughts, inattention, memory loss, striking changes in personality and the affect, hallucinations, delusions, decreased level of consciousness. And the patient may experience rapid alteration between mental states such as lethargy and agitation, where they're calm one second and jumping around like a grasshopper the next. Symptoms of delirium may mimic intoxication, drug abuse, or severe psychological disorders such as schizophrenia. Delirium is discussed in detail in Chapter 35, Geriatric Emergencies. There can be other causes of altered mental status. Consideration of other possibilities becomes important because a patient with altered mental status may be combative and refuse treatment and transport. You also may be dealing with an unrecognized head injury, and in most cases, a patient who appears intoxicated is just that. However, you must consider other problems. They may also be struggling from psychological disorders and medication complications, and that's causing their altered mental status. Another possibility is infections that may cause altered mental status, particularly those involving the brain or bloodstream. Now let's talk about patient assessment. Of course, the number one priority is always scene safety, so do a proper scene size up. When you're checking the scene for safety, you need to remember this. In some calls to the dispatcher, the description of the patient's signs and symptoms will usually provide a fairly good idea of what the problems may be, and the dispatcher will be able to convey this information to the responding crew. Patients who have an altered mental status may exhibit a wide range of signs and symptoms and behaviors. The most significant difference between an altered mental status and other emergencies is that your patient cannot tell you reliably what is wrong. Do not be distracted by the seriousness of the situation or by frightened family members. Make sure to maintain your focus, the patient, and your safety, the patient's safety, and that of your crew. And look for threats to your safety and follow standard precautions. Consider the need for spinal immobilization based on dispatch information and your assessment of the scene. And call for additional resources early. You must also consider the mechanism of injury or the nature of illness. Look for clues to help you determine the nature of illness. There are special considerations for a patient with a suspected neurologic emergency. There must be an evaluation of the environment, assessing for any signs of potential trauma. There may also be indications of a previous medical condition. Now, as far as evidence of a seizure, that may be present, and ask family when was the last time the patient appeared normal. During your primary assessment, remember that your first priority is to look for and treat life-threatening conditions. Perform a rapid exam as you approach the patient. Gather information from the scene, both visually and from people who may be there, and then make sure you also note the patient's body position and level of consciousness. This initial impression will help you determine the severity of the situation. You should be able to tell if a seizure is taking place. Unless you are stationed extremely close to the scene, most seizures will be over by the time you arrive. If the seizure is still occurring, status epilepticus may be present. Use the AVPU scale. Now let's discuss airway and breathing. Stroke patients may have difficulty swallowing and are at risk for choking on their own saliva. Evaluate the airway of an unresponsive patient to make sure it is patent and will remain so. Be prepared to provide suction. Position the patient to prevent aspiration. Check for foreign body obstruction. Assess the patient's breathing. All patients with an altered mental status, regardless of the cause, should receive high-flow oxygen. It is important to ventilate the patient at the appropriate rate with the proper volume. Deliver each breath during a period of 1 second at a rate of 10 to 12 breaths per minute. Do not hyperventilate the patient. Hyperventilation may have several negative consequences. It overinflates the lungs, which can impair blood return to the right atrium and cause a decrease in cardiac output. It can also increase the risk of regurgitation and aspiration into the lungs of stomach contents. It could cause severe injury in patients with intracerebral bleeding and increased intracranial pressure, causing cerebral vasoconstriction, causing further injury to the brain. In regards to circulation, begin by checking the pulse if the patient is unresponsive. If no pulse is found, immediately begin CPR and attach an AED. If the patient is responsive, determine the pulse and whether or not it is fast or slow, weak or strong. Evaluate the patient quickly for external bleeding. In regards to your transport decision, establish your priorities based on your assessment of the patient's level of consciousness and ABCs. If you suspect the patient is having a stroke, you should rapidly transport the patient to an appropriate facility. With history taking, you need to investigate the chief complaint. If the patient is unresponsive, gather any history of the present illness from family or bystanders. If no one is around, quickly look for explanations for the altered mental status, such as incontinence or a bitten tongue. In a responsive patient, ask him or her what happened. Evaluate the patient's speech. Gather a sample history. Remember that time can be critical in a neurologic emergency. Make a special effort to determine the exact time that the patient last appeared to be healthy and normal. Collect or list all medications that the patient has taken. Patients who have had a stroke may appear to be unconscious and unable to speak, but they may still be able to hear and understand what is taking place. Try to establish effective communication. Your history should reveal if the patient has a history of seizures. Find out if this episode differs from previous episodes and what medications the patient is taking. Note these medications used to treat a seizure disorder. There may be more than one, so make sure to note any and all medications used to treat a seizure disorder. If the patient does not have a history of seizures, a serious condition should be suspected. The secondary assessment. You want to perform your physical examination, and your assessment should continue with this secondary assessment of the entire body, paying special attention to the particular system involved. If you suspect your patient is having a stroke, direct particular attention to your neurologic assessment. Vital signs. Patients with significant intracranial bleeding may have a great deal of pressure in the skull that is compressing the brain. This slows the pulse and causes respirations to be erratic. Blood pressure is usually high to compensate for poor perfusion in the brain. Unequal pupil size and reactivity indicate specific bleeding and pressure on the brain. If the patient has an altered mental status, you should check the glucose level if you have the equipment available. During most active seizures, it is impossible to evaluate vital signs, and this should not be your priority. In most cases, vital signs of a patient in a postictal state will be close to normal limits and parameters. In regards to monitoring devices, use a portable blood glucose monitor to check blood glucose levels. You may also use non-invasive blood pressure methods to monitor blood pressure. Stroke assessment. Rapidly identify stroke in the field with a stroke scale. Stroke scales evaluate the face, arms, and speech. The Cincinnati Pre-Hospital Stroke Scale and the Los Angeles Pre-Hospital Stroke Screen are commonly used. To test speech, ask the patient to repeat a simple phrase. To test facial movement, ask the patient to smile, showing his or her teeth. To test arm movement, ask the patient to hold arms in front of his or her body, palms upward to the sky, with eyes closed and without moving. The 3-item stroke severity scale, or LAG, looks specifically at 3 items: level of consciousness, arm drift, which indicates motor function, and gaze. The fast mnemonic we're going to discuss now, and the F in fast stands for facial droop, A is arm drift, S is speech, and T is time, and refers to the time the patient last acted normally. So make sure if you suspect if you suspect seizures, that you use the fast mnemonic. And it would be actually true for stroke and or seizure. This is table 17-3 and is the Cincinnati pre-hospital stroke scale that I just talked about. Here is table 17-4, which outlines the Los Angeles pre-hospital stroke screen. And this is the 3-item stroke severity scale. In all three of these, the Los Angeles screen, the Cincinnati screen, and this, the 3-item stroke severity screen, I had just talked about in slides just previous to these tables. Become familiar with these tables so that when you get out in the field, you know what steps to take without leaving any out. All patients with an altered mental status should also have a Glasgow Coma Scale or GCS score calculated. The table on this slide displays the Glasgow Coma Scale or GCS. This is table 17-6. It's in your text. And it scores the patient's responsiveness through eye opening, verbal response, and motor response. This is very important. So please make sure that you know this table and this assessment, the Glasgow Coma Scale, know the 3-item scale, the Los Angeles stroke screen, and the Cincinnati stroke screen. In terms of reassessment, when you reach the point of doing a reassessment, you want to make sure you focus on reassessing their ABCs, vital signs, and review interventions that have been provided to the patient up to the point where you have reached the reassessment stage in their care. Patients who have had a stroke can lose their airway or stop breathing without warning. There are multiple interventions that may be necessary. These interventions include use of airway adjuncts, positive pressure ventilations, and other treatments. If an intervention is not working, try something else. Compare baseline information with updated information. Notify the receiving facility of your patient's chief complaint and your assessment findings. Local protocol will tell you if the designated stroke centers in your call area want you to call in a quote-unquote stroke alert for patients you have assessed and found to be having a stroke. Report the time that the patient last appeared to be healthy and functioning normally. Report the findings of your neurological examination and the time you anticipate arriving at the hospital. For patients who have had a seizure, give a description of the seizure activity if known, and if the patient has a history of seizure activity, determine how often the seizures occur and if there's any history of status epilepticus. Document interventions and the patient's response. Some conditions are easier to identify, and there are treatment options that are readily available. The cause of other neurologic emergencies may not always be obvious to you, and this may make it difficult for you to provide definitive care in the field. In most patients with suspected stroke, physicians in the emergency department need to determine whether there is bleeding on the brain. The only reliable way to tell this is with a CT scan of the head. If there is no bleeding, the patient may be a candidate for blood clot dissolving medication. However, if bleeding is present, this type of medication will increase bleeding with disastrous consequences. Some EMS systems designate specific hospitals, typically accredited stroke hospitals, for patients who may be having a stroke. Notify the hospital staff as early as possible if you have a quote-unquote stroke alert patient. Only a limited number of treatments are available that are effective if started more than 3 hours after the stroke began. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms of a stroke. Patients who have had a seizure require definitive evaluation and treatment in the hospital. Supplemental oxygen is strongly advised. Most seizures will not require a significant amount of intervention on your part. For patients who are having a seizure, make sure to protect them from harm. Maintain a clear airway by suctioning. Provide oxygen as quickly as possible. If head or neck trauma is suspected, provide spinal immobilization. For patients who continue to have a seizure, as in static epilepticus, make sure to suction the airway, provide positive pressure ventilations, and transport quickly to the hospital. Rendezvous with ALS if possible. With headache, most headaches are harmless and do not require emergency medical care. You should be concerned if the patient complains of a sudden onset severe headache, a sudden headache with fever, seizures, altered mental status, or following some type of trauma. And with migraines, always assess the patient for other signs and symptoms that might indicate a more serious condition. Apply high-flow oxygen if tolerated. Provide a darkened and quiet environment. Do not use lights and sirens during transport. With stroke, support ABCs and provide rapid transport to a stroke center. The patient may require manual airway positioning. Use suction as needed and monitor the patient's oxygen saturation with a pulse oximeter. Maintain an oxygen level or SpO2 level of at least 94%. Routine use of oxygen therapy is not recommended unless the patient is experiencing respiratory distress or is showing signs of hypoxia. A patient's paralyzed extremities will require protection from harm. Continuously talk to the patient and inform him or her of what is happening. Thrombolytic therapy or blood clot dissolving drugs and methods to mechanically remove the blood clot may reverse stroke symptoms and even stop the stroke if given within 3 hours in terms of use of drugs, or 6 hours in terms of mechanical methods like surgery. Comprehensive stroke centers are able to offer advanced stroke care and in some cases may be able to provide thrombolytic therapy even after the 3 and 6 hour window. Proceed under the assumption that an area of the brain can still be saved. The sooner treatment is done, the better the patient's prognosis. Spend as little time at the scene as is possible. Stroke is an emergency and time is brain. If you think about it from that standpoint, the less time you chew up, the more brain can be saved. So time is brain. If possible, transport to a designated stroke center. With emergency care in relation to seizures, the patient may be in post-ictal state upon your arrival. Alternatively, the patient may still be having the initial seizure that you were called about. So make sure to continue and assess and treat ABCs. Try administering oxygen. It is difficult to safely prepare a patient for transport who is having a seizure. Assess them for trauma. Use spinal immobilization if indicated. Never attempt to restrain a patient having a seizure. A couple of things that are really important here. When you assess for trauma, somebody who's having a seizure may have thrown out an arm or leg, and because the seizure can cause such intense muscle contractions, they could actually break something. Or they may have their neck muscles tighten and release and tighten and release, and it can cause them to bang their head against the floor inadvertently. So that's something that you want to check for. Assess for any trauma they may have suffered during the seizure, and then also never attempt to restrain a patient having a seizure. The first thing is, because they're full of adrenaline and they have these intense and strong muscle contractions, they aren't aware of it, but they can end up really banging you up as a responder. And then the other side of that is, if you try to restrain them, they can force against that restraint and break bones. So make sure you are very careful to stay within these treatment guidelines. It's for the patient's safety and your safety. Not every patient who has a seizure wants to be transported. It is usually in the patient's best interest to be evaluated by a physician. Your goal is to encourage the patient to be seen by a physician and be prepared to discuss the situation with hospital staff. If the patient still refuses transport, ask yourself the following questions. Is the patient awake and completely oriented after a seizure? In other words, do they have a Glasgow Coma Scale or GCS score of 15? Does your assessment reveal no indication of trauma or complications from the seizure? Has the patient ever had a seizure before? Was the seizure the quote-unquote usual seizure in every way in terms of length, activity, and recovery? And then ask, is the patient currently being treated with medications and receiving regular evaluations by a physician? In relation to altered mental status and care, the signs and symptoms may vary from simple confusion to coma. Regardless of the signs or symptoms, altered mental status is always an emergency that requires immediate attention, even if the cause appears to be intoxication or minor head trauma. Now let's go over the review questions for this chapter and see how you do. First question, a 41-year-old man presents with slow, irregular breathing, hypotension, and dilated pupils. These signs most likely indicate dysfunction of the A, brainstem, B, hypothalamus, C, cerebrum, or D, cerebellum. Remember which regions of the brain control which things. So again, 41-year-old man who presents with slow, irregular breathing, hypotension, and dilated pupils. Which part of the brain normally manages these things? Take a look at the answer, and I bet you'll get it correct. It is A, the brainstem. The brainstem is responsible for functions such as breathing, blood pressure, and pupil constriction. Brainstem dysfunction would result in abnormal findings with these functions. The brainstem regulates all of the autonomic functions in the body. So the correct answer here is brainstem. Let's look at the incorrect answers. B, hypothalamus. Remember I said make sure you learn which regions of the brain do what. Hypothalamus is incorrect because the hypothalamus causes changes to occur in heart rate, body temperature, and thirst. The cerebrum is incorrect because the cerebrum causes changes to occur in emotion, thought, touch, and movement. And cerebellum is incorrect because the cerebellum causes changes to occur in muscle control, body coordination, standing, walking, and writing. Remember, the symptoms he's presenting with are autonomic functions versus the cerebellum, which causes changes to occur in muscle control, body coordination, standing, walking, and writing. So make sure, again, you know which section of the brain controls what, and make sure you also know the difference between autonomic function versus function where the patient has control over things. An acute ischemic stroke is caused by A, a ruptured cerebral artery, B, increased intracranial pressure, C, an acute rise in the person's blood pressure, or D, a blocked cerebral artery. Know your definitions. If you look at the definition of what an ischemic stroke is and look at your answers, I know you'll get this one correct. It is D. There are two types of stroke, hemorrhagic and ischemic. Hemorrhagic stroke is caused by a ruptured cerebral artery or aneurysm, which causes bleeding within the brain and increased intracranial pressure as a result. An ischemic stroke is caused by a blocked cerebral artery, either from a clot that grows locally, which is a thrombus, or that travels to the brain from another part of the body, which is an embolus. So let's look at the incorrect answers. An acute ischemic stroke is caused by a ruptured cerebral artery. That's incorrect. A ruptured artery is a hemorrhagic stroke. That's easy to remember. If you just think hemorrhage is bleeding, hemorrhagic stroke caused by a ruptured artery. Very easy to remember. Increased intracranial pressure. The actual pressure can be caused by swelling, bleeding, or tumors. So an acute ischemic stroke is not caused by increased intracranial pressure. The increased intracranial pressure is a result of other things happening, like swelling, bleeding, or tumors. An acute ischemic stroke is caused by, let's look at these last two answers. C states an acute rise in a person's blood pressure. That's not the cause of an ischemic stroke. An acute rise in a person's blood pressure is actually called or known as a hypertensive crisis. D would be a blocked cerebral artery. That's the correct answer because that is what causes an ischemic stroke. Review question 3. A 56-year-old man experienced a sudden severe headache and then became unresponsive. He has a history of high blood pressure. The most likely cause of his condition is A, a hemorrhagic stroke, B, an acute ischemic stroke, C, severe migraine headache, or D, a transient ischemic attack. Think back, we talked about sudden severe headaches and history of high blood pressure. And the answer is A. A hemorrhagic stroke is typically preceded by sudden severe headache, which signals the rupture of a cerebral artery, after which the patient becomes unresponsive due to bleeding within the brain. Ischemic strokes and transient ischemic attacks generally do not cause a sudden severe headache, and migraine headaches typically do not cause a loss of consciousness. So let's look at the other answers. B, acute ischemic stroke. And we just talked about this in reviewing the correct answer. Acute ischemic stroke most of the time does not cause a sudden severe headache. Letter C, sudden severe headache followed by unresponsiveness is C, severe migraine headache. That's incorrect because this generally does not cause a loss of consciousness. No matter how bad a migraine headache can be, and they can be murderously bad, they just don't cause loss of consciousness. And D, the option was transient ischemic attack. Again, this type does not generally cause a sudden severe headache. Review question 4. Unlike an ischemic stroke, a transient ischemic attack is characterized by all of the following except A, symptoms that resolve within 24 hours, B, symptoms that persist for longer than 24 hours, C, weakness or paralysis to one side of the body, or D, an acute onset of confusion and slurred speech. Just remember the observations and symptoms that characterize an ischemic attack, and then you'll be able to eliminate the one option here that is not correct. And the answer is B. Signs and symptoms of a transient ischemic attack, or TIA, are usually identical to those of an acute ischemic stroke, including hemiparesis, slurred speech, confusion, and facial droop. Unlike the ischemic stroke, however, the symptoms of TIA usually resolve within 24 hours. So let's look at the other answers and see why they are all true and this one was incorrect. So to review, unlike an ischemic stroke, a transient ischemic attack is characterized by all the following except A, symptoms that will resolve within 24 hours. That is actually a hallmark of TIA, or transient ischemic attack. So that one's actually correct. B, all of the following except symptoms that persist for longer than 24 hours. We know that's not true because we just pointed it out in A. TIA, the symptoms will resolve in 24 hours or less. If you have symptoms that persist for longer than 24 hours, that's not a transient ischemic attack. C is also correct because let me just review the question again. Unlike an ischemic stroke, a transient ischemic attack is characterized by all the following except C, weakness or paralysis to one side of the body. That's actually true of an ischemic stroke. It is a sign of a TIA. And D, an acute onset of confusion and slurred speech. Again, that is also a sign of a transient ischemic attack. So go back and review this question carefully. And make sure when you're taking tests or any type of examination related to this material, or when you're studying it, make sure that you read questions carefully and thoroughly. But make sure you review this one. A patient with a suspected stroke presents with slurred speech that is difficult for you to understand. This is referred to as aphasia, dysphagia, or dysarthria. So if you remember what each of these terms means, you should be able to, by process of elimination and knowing the definitions of these, know what they're asking about here in the question, which is again a patient with a suspected stroke presents with slurred speech that is difficult for you to understand. Which of these words has a definition that matches this suspected stroke patient? It is D. Dysarthria is defined as slurred, poorly articulated speech. It is common in stroke patients. Dysphagia is defined as difficulty speaking. The patient's speech may or may not be slurred. Aphasia is the inability to speak at all. And dysphagia is defined as difficulty swallowing. So again, just to remind you of the definition of each of these words. In this case, dysarthria, letter D, is what was put to you in the scenario in the question. Dysarthria is defined as slurred, poorly articulated speech, and it is common in stroke patients. Dysphagia, with an S, is defined as difficulty speaking in general. The patient's speech may or may not be slurred. Aphasia is the inability to speak at all. And dysphagia with a G is defined as difficulty swallowing. Now, since we've covered all of these options in the review for the correct answer, I'm not going to review them here, but go through and make sure you understand the definition of aphasia, dysphagia, and dysarthria. Question 6. A type of seizure that is characterized by severe twitching of all of the body's muscles and lasts for several minutes or longer is called a partial seizure, an absence seizure, a tonic-clonic seizure, or a generalized seizure. Let's see if you can guess the right answer, and let's review it now. It is D, a generalized seizure. Generalized seizures are characterized by generalized severe twitching of all of the body's muscles, and they often last for several minutes or longer. An absence seizure is characterized by a blank stare, and the generalized muscle twitching all over the body is actually absent. So again, to make sure that you're clear on this, because it might be referred to with the old terminology, generalized seizure means it's a full body involvement. The electrical storm is happening in the brain and also causing all the muscles in the body to contract spasmodically and randomly and last for several minutes or longer. That is what used to be known as, and people still refer to as, a grand mal seizure. An absence seizure is characterized by a blank stare. You don't have the generalized muscle twitching all over the body, but you do still have the electrical storm in the brain, which is why the patient kind of checks out. Their gaze fixates on something, and even though their body's not twitching, there's still an electrical storm going on in the brain, which is why they're just unable to respond to anything around them at that point. And that used to be called a petit mal seizure. Let's look at the other two answers. Just to review the question, a type of seizure characterized by severe twitching of all of the body's muscles and lasting for several minutes or longer is called an A, partial seizure. And that's not correct, because a partial seizure is broken down into simple jerking of one part of the body, and complex, which produces changes in behavior and emotion. So that's not what's being described in your review question here. B, absence seizure. That's not correct, because what is being described in the review question is not an absence seizure. Absence seizure doesn't involve any changes in the motor activity of the body. C, tonic-clonic seizure. That's not correct, because a tonic-clonic seizure exhibits muscle contraction and incontinence. And in this particular type of scenario it's laid out to you, incontinence is not mentioned at all. And D, generalized seizure, and that's the correct answer, because that's exactly what's being described to you here. Question 7. The most important reason for promptly transporting a stroke patient to the hospital is A, a transient ischemic attack that can be ruled out. B, medications may be given to reverse the stroke. C, the clot in the coronary artery may be dissolved. Or D, he or she needs close blood pressure monitoring. Okay, so again, the most important reason for promptly transporting a stroke patient to the hospital. Review these and let's find the correct answer. The answer is B, Fibrinolytic medications or clot busters have been shown to reverse the symptoms of a stroke by dissolving the clot that is blocking the cerebral artery. However, for the patient to be eligible for this therapy, it must be initiated within 3 hours max after the onset of symptoms. For this reason, prompt transportation of the stroke patient is absolutely critical. Let's look at the other answers, other options for answers you were given. Number 7 again, the most important reason for promptly transporting a stroke patient to the hospital is because, well, A says a transient ischemic attack can be ruled out. That's not correct. In a TIA, stroke symptoms resolve on their own, usually in less than 24 hours, and present no neurologic deficits. B, medications may be given to reverse the stroke. Again, that's the correct answer. C, the clot in the coronary artery may be dissolved. Well, a coronary artery is in the heart. Remember, if you think back to the circulatory system when we were talking about this, there are 5 coronary arteries that feed different areas of the heart. Well, coronary arteries are in the heart, not the brain. The arteries in the brain are called cerebral arteries. So that obviously is not correct. And D, he or she needs close blood pressure monitoring. Well, that's not correct either, because monitoring of a patient's blood pressure is important, but more critical in this case is dissolving the clot and stopping the progression of damage, and that right now is the most important thing. Question 8. Which of the following are components of the Cincinnati Pre-Hospital Stroke Scale? A, arm drift, blood pressure, and speech. B, speech, pupil response, and arm drift. C, facial symmetry, speech, and arm drift. Or D, pupil response, facial droop, and speech. Now, when you're doing your homework, taking pop quizzes, etc., or here, pull out your table and look at the Cincinnati Pre-Hospital Stroke Scale, and you'll see exactly what it's looking for. So let's see if you figured out the correct answer. It is C. The 3 components of the Cincinnati Pre-Hospital Stroke Scale are facial symmetry, speech, and arm drift. Both sides of the patient's face should move symmetrically or equally when he or she smiles. The patient's speech should be easily understandable and without slurring. The patient should be able to hold both arms out in front of his or her body with eyes closed and palms up without one arm drifting down to his or her side. Let's look at the other possibilities. Which of the following are components of Cincinnati Pre-Hospital Stroke Scale? A, arm drift, blood pressure, and speech. That's not correct because Cincinnati scale does not use blood pressure. B, speech, pupil response, and arm drift. That's not correct because the Cincinnati scale does not use pupil response. C are the components that it actually measures, and this is the correct answer. And those components are facial symmetry, speech, and arm drift. D, pupil response, facial droop, and speech. And scale does not use pupil response. Again, that's incorrect. 9. Your patient opens his eyes when you say his name, is making incomprehensible sounds, and withdraws when you pinch his earlobe. What is his GCS score? GCS, Glasgow Coma Scale. Pull out the table, look at the Glasgow Coma Scale, check out his points on the scale by looking at his presentation and see how you scored it. It is A. The Glasgow Coma Scale gives a score of 3 to a patient who opens his or her eyes in response to speech. Incomprehensible sounds has a score of 2, and withdrawals to pain has a score of 4. When added together, this patient's GCS score is 9. So you measure each of those components take the points from each, add them up, and that gives you your GCS score, a Glasgow Coma Scale score. Because we just reviewed how to do it properly, I'm not going to give you the answers to B, C, and D. Obviously, they aren't the right score. So, like the other tables that we just reviewed and were mentioned in the lecture, make sure you pull out the table for your Glasgow Coma Scale and, get to know it. So you're able to score accurately, and until you are completely comfortable with it, use it for reference. Better to get it right than not. That's not cheating. That is called perfecting your skills and knowledge. Number 10, if a patient complains of a severe migraine, how should she be transported? A, in a brightly lit ambulance so she can see while her vision is impaired. B, with loud sirens so she can get to the hospital as soon as possible. C, without lights and sirens. Or D, this patient should not be transported. If you think about the symptoms of severe migraine and what the patient experiences, this one should be blatantly obvious in terms of the correct answer. It is C. Treatment of a migraine headache is supportive. However, you should always assess the patient for other signs and symptoms that might indicate a more serious one. Applying high-flow oxygen, if tolerated, may help ease the patient's condition, and when possible, provide a darkened and quiet environment because patients are sensitive to the light and sound. Do not use lights and sirens during transport. Let's look at the other answers. If they complain of a migraine, how should they be transported? In a brightly lit ambulance so that she can see while her vision is impaired. So in other words, send her in a brightly lit ambulance. She's light sensitive, so her vision is impaired. So why would you stick her in a bright light ambulance? Obviously, that's not correct. With loud sirens, so she can get to the hospital as soon as possible. No way. If you turn on the siren and lights, a migraine patient will just, they'll be ready to hit you. They'll be like, just turn it all off because they can't, they're hypersensitive to light and sound. And ambulances are all about light and sound. So make sure you take into consideration what a migraine patient is suffering in terms of symptoms. C, without lights and sirens, that's obviously the correct answer. Or D, this patient should not be transported. Well, a migraine, especially if they've never had one before, but anytime there's a migraine, it can indicate a more serious condition. A migraine can be an early onset of something much more serious. So, yeah, they should be transported. Okay, very good class. Thank you for all of your attention. Make sure again to pull out your tables for Glasgow Coma Scale, Cincinnati Pre-Stroke Hospital Scale, Los Angeles Pre-Stroke Hospital Scale, or Pre-Hospital Stroke Scale, and all of the other tables and charts that we went over in this chapter. Make sure to review them and use them until you have them completely memorized. But anytime that you might need to refer to them, have them handy so that you know them. But then again, also make sure that you review carefully seizures, strokes, etc. Because all of these either already are serious or present issues that could become serious. So again, thank you for your attention, and we'll see you next class.